Hello everybody, welcome back to Remedy OMM. Today we'll be going over the cervical spine and how to diagnose somatic dysfunctions of the cervical spine. All in all, a short but very important lecture.
Looking to elevate your ComLex prep? Dive into RemedyOMM.com. Discover our comprehensive question bank, expert lectures, and personalized consultation services, all tailored for your success. Join the community of achievers. Visit RemedyOMM.com today and take the next step in your medical journey.
Here's the topics we'll be going over today. I will touch on cervical spine anatomy and go through the important joints that you need to know and be aware of to diagnose cervical spine dysfunctions. I will also go through some general treatment guidelines to help build your foundation. The cervical spine, compared to the thoracic or lumbar spine, has some unique structures. These structures allow the cervical spine to be broken down into three main sets, as you can see here. And we'll talk more in depth about these sets as we go through this lecture. The first set is the joint between the occiput and C1, which you can see here in the image. If you look on the right, you will see an image of the skull with the bones identified. It is very important to know your anatomy when it comes to the skull, and we'll learn more about this in the cranial lecture. But for now, it is important to note that the occiput is the most posterior inferior bone on the skull. Sometimes people will refer to the occiput as C0, so keep this in mind when answering questions on exam. The vertebrae that articulates with the occiput is C1, which we call the atlas. The reason C1 is also known as the atlas is because of the mythological Greek titan Atlas, who was punished by holding up the earth. For this analogy, think of your skull as the earth, and C1 is the atlas holding it up. We call this articulation the occipital atlanteal joint, or for short we call it the OA joint. The primary motion of the OA joint is flexion and extension. It is responsible for approximately 50% of flexion and extension of the cervical spine. There's two extremely important points to understand about the OA joint. The first is that because of the bone's unique structure and articulation, it doesn't exactly follow Fryette's principles. Instead, people say that the OA exhibits type 2-like somatic dysfunctions. What does this mean? Well, this means that when the OA has a somatic dysfunction, it will be flexed or extended, but instead of having rotation and side bending to the same side like we normally see, it will have rotation and side bending to opposite sides. So you will see a diagnosis such as OA, flexed, rotated left, side bent right. This is key to getting the correct diagnosis of OA joints. The next point is without a doubt one of the highest yield points of the entire lecture. If you walk away with one thing from this lecture, it is this next point. Somatic dysfunctions that occur at the OA joint can and will affect cranial nerve 10, the vagus nerve. If you recall from the viscerosomatics lecture, the vagus nerve innervates some of the most important structures through the parasympathetic nervous system. And the reason OA somatic dysfunctions will affect the vagus nerve is because of the way the vagus nerve exits the skull through the jugular foramen. Diagnosing a somatic dysfunction of the OA joint can vary between providers depending on preferences or skills, but in my opinion, the easiest way to diagnose OA joint dysfunction is to go by the following steps. First, find the OA joint and focus on palpating C1. Next, you'll want to test translation of C1 to the right and to the left to determine which direction the joint may be side bent. Remember from the somatic dysfunction lecture, translation is opposite to side bending, so if C1 translates easier to the left, then the OA joint is side bent to the right. Once you've figured out the side bending component, you will need to see and test if translation gets better or worse with flexion or extension. We name the somatic dysfunctions for the direction of ease, or the direction the patient's body wants to be in. So if flexion worsens the asymmetry of the translation from side to side, then the patient wants to be extended. And with those two pieces of information, side bending and flexion or extension, and knowing that these dysfunctions are type 2-like, you will be able to determine the rotation aspect of this joint. The second set is the atlantal axial joint, or atlantoaxial joint. This is the articulation between C1 and C2. C2 is also known as the axis, hence the name atlantal axis joint. The C2 is without a doubt the most unique structure of the entire spine. As you can see in the image, C2 has this prominence here that protrudes upwards and goes into C1. This structure is known as the dens. The way the dens articulates with C1 limits any flexion or extension of this joint. In fact, the AA, the atlantoaxial joint, is responsible for approximately 50% of rotation of the entire cervical spine. Because of this, when palpating for any AA dysfunction, the only abnormality to look for is in rotation, which makes things a little simpler for us to diagnose. Test rotation and remember to name the somatic dysfunction for the direction of ease. The last set are the typical cervical segments. These are much simpler for us to understand because we have covered type 2 mechanics before, and these cervical segments follow type 2 mechanics with rotation and side bending occurring to the same side. It's important to remember here that there's a lot of important structures in this segment of the cervical spine. We have nerve roots which branch out laterally to form the brachial plexus, and we have important vascular structures nearby, including the carotids bilaterally. In addition to all that, we have muscle attachments that are important in assessing for neck pain, rib dysfunctions, and even headaches. Some general treatment considerations to keep in mind when treating the cervical spine are: first, to use indirect techniques. As we mentioned, there are important structures in this region, so we don't want to apply too much stress to these structures. Using indirect techniques first will help avoid situations that may cause more problems. With that in mind, if you are going to use direct techniques, I would caution as to using HVLA as a last resort, and if you do, the recommendation is to make sure that the cervical spine is in a flexed position, as extension can cause a risk of vertebral artery dissection. Remember that there are many important muscular attachments in this region, so treating the upper thoracic spine and ribs may help in treating cervical segment dysfunctions. That's all I have for you guys today. Thanks for watching. Please like and subscribe. Your support means the world to us and our channel. If you have any questions, please don't hesitate to comment below. Check out RemedyOMM.com to take your osteopathic skills to the next level with our comprehensive question bank. We will see you guys in the next lecture.